Of course. Thank you so much for the invitation. It's been kind of fun listening to you guys say hello and the backgrounds and where people are coming from. And Laura doing so well. Congrats to Laura. I really appreciate the invite to talk about this stuff today. Breast cancer risk is certainly one of my biggest passions, clinically and from a research standpoint. I have a few other interests, as you've heard, but this is certainly one of my primary focuses. And so I'm really excited to be here to talk to you about this today. I'm going to go ahead and share my screen. So hopefully that works. You can see my slides, but not my notes.
Yep.
Yep, perfect. All right, so today I was asked to talk a little bit about Hodgkin's and breast and kind of the overlap between the two. Of course, I happen to be a breast surgeon, so you're going to get the surgeon's perspective today. I do include some information about just breast cancer in general, because I think it helps to kind of compare what you guys have and what you might go through and your risk to what the average woman's risk is, because I think it gives us a little bit more perspective or context for the things we'll talk about that apply to you specifically. That being said, I also want to recognize, just like average risk women are not all the same, I understand Hodgkin survivors are not all the same. I know you've all had different treatments at different times. You are at different phases in your development during that time, and all of that plays into it. So just remember that the things we talk about are kind of generalities, and it may or may not be specific to you. I had a patient I saw once in clinic who was not happy when I gave her these generalities, but unfortunately, that's kind of what exists out there. So it's just because you guys all have something a little bit different about your treatments or the diagnosis and the timing of that. So it's all we can talk about really are generalities. So I hope this is helpful for you. So again, just starting a little bit with breast cancer in general, breast cancer is the most common non-cutaneous malignancy in the United States today. You can see that almost 300,000 women will be diagnosed with breast cancer each year, so in 2022 alone. And estimated deaths from breast cancer are also over 40,000. So again, a very common cancer, and also unfortunately results in a lot of deaths in this country. So the average woman's risk of developing breast cancer turns out to be about 1 in 8. Again, this isn't specific to your population, but to the average risk woman. So 1 in 8 women in general will develop breast cancer at some point during her lifetime. And that translates to about 1 in 40 women who will ultimately die from breast cancer. So obviously, but we want to prevent that, right? We don't want people to be dying from breast cancer or any other cancer, but today we're going to focus on breast. And one of the ways that we can prevent that is by catching it very early. So that doesn't prevent breast cancer, but certainly catches it at a state when it's very treatable and ideally very curable. So what I wanted to start off today talking about is breast cancer screening. Again, I'm going to talk a little bit about the general population, and then we're going to talk about Hodgkin survivors more specifically. So, it used to be that mammography was pretty straightforward when it came out. First there was a little slow uptake, but once it got out into the community, it was every woman needs a mammogram and she should start that mammogram at the age of 40 and she should just do it every year. And that was easy, right? Because we thought, well, all women are the same, so they must all need the same screening. So we treat them all the same test, the same timing, really no individualization of it. But of course, we realized that's not exactly how this should probably work. All women are a little bit different. They have different risk factors for breast cancer. They're different ages. They have different desires, right? What if the patient doesn't want to do these kinds of things? And so because of that, we have lots of different options now. So it's not just mammograms, it's do you want the 3D mammogram or the mammogram with tomosynthesis? There's even contrast enhanced mammography now. There's breast MRIs, there's breast ultrasound. There's a lot of talk out there about breast density. What does that mean and how do we deal with that? There's women who are average risk, there's high risk. You can start at 40, you can start at 45. You can do it every year, you can do it every other year. So you can see there are a lot of decisions that have to be made when it comes to breast cancer screening. And it's all about individualization or personalization of that screening for the person that's sitting across from you. Even the guidelines these days are all over the board. So this is just a summary of just some of the more common guidelines that we will refer to. They're from the American College of Obstetrics and Gynecology, or ACOG. ACR is the American College of Radiology and Society of Breast Imaging. Here we've got the American Cancer Society towards the middle. We've got the American College of Physicians. NCCN is a popular one. Many of you might be familiar with the NCCN. It's the National Comprehensive Cancer Network. They put forth guidelines on not only breast cancer screening, but all types of cancer, not only for screening, but also risk and also treatment. In fact, most of their guidelines are treatment focused. How do you treat any given cancer, whether that be Hodgkin's or breast cancer? And then, of course, we've got the government guidelines, which is the United States Preventative Services Task Force. And so among all of these, you can see that the age to start mammograms varies widely. Some say 40, some say 50, some say discuss it earlier, some say later. And then they, even more confusingly, have no idea when to stop mammograms. So you could stop them at 75, you could stop them based on life expectancy, you never have to stop them. And then the last thing is, how often do you do that mammogram? Do you do it every year? Do you do it every other year? Do you do it every year for a while and then switch to every other year? So you can see, because there's so much variation here, that's really trying to account for the individuality of the patient. And so again, trying to tailor what's the right plan for the person in front of you. And really, whatever you guys come up with, there's going to be a guideline to pretty much support that. So let's talk about some of the different screening tests. So it looks like, I wasn't sure how old the people on the call would be today. I thought maybe there'd be one or two who had not had any real breast imaging. So if that's the case, this is for you. If not, I apologize to all of you that know what all of these imaging tests are, but probably just a good refresher. So a mammogram. This is going to be the most common tool that we use when screening for breast cancer. And essentially, it's just an X-ray. And so what's going to happen is you come in and they're going to take the breast and they're going to take two very hard, often cold paddles, and squish the breast top to bottom and squish the breast side to side. And in each squish, they're going to take a picture. And that X-ray is going to show us not only the breast tissue, but if there's any abnormalities that are starting to develop. So of course, now we have the 3D mammograms, and this is what that machine looks like. So it's, again, the same squish of the breast, but instead of taking one picture, they're going to kind of scan through the breast. So you'll see this machine here with the woman facing it, and it kind of rotates around her and takes kind of slices of the breast, kind of similar to an MRI or a CT scan. Not quite as many pictures, but a similar concept. Then probably another more common test is going to be the breast ultrasound. Now, lots of people will get breast ultrasounds, but they're usually for diagnostic purposes. But we've also seen an increase in the number of women who get screening breast ultrasounds. And that can be done in one of two ways. It can be done by handheld, meaning there is a person standing there holding that ultrasound probe in her hand. And that's the person in the bottom right-hand corner. And you can see she's just scanning the woman's breast, just running that probe right over the breast tissue. And then in the bottom left, that's what we call automated breast ultrasound. So you can see it's more of a machine that you kind of scan over the breast. And as it does that, it kind of has an automatic way that it takes snapshots of the breast tissue. And then last but not least, that we're going to talk about today is breast MRI. So breast MRI is a very popular tool used for breast cancer screening, particularly for high-risk women. So I imagine some of you on the call have had a breast MRI, but for those of you who have not, it is the tunnel you have to go into. So that's kind of what you're seeing here in this, it's sort of the top right picture. You can see the tunnel where they're going in. Arms are up over the head, as you can see there, and the breasts are going down through a cutout in the table. For a breast MRI, you do have to get contrast, and that contrast for a breast MRI is a gadolinium-based contrast, and that's different than the type of contrast you get for a CT scan. So for CT scans, you get an iodinated contrast. And I point that out because some women are allergic to contrast and don't realize that there are different types of contrast. So just because you're allergic to the contrast you got for a CT scan does not mean necessarily that you'll be allergic to the contrast you would get for an MRI. So unfortunately, you would have to get it in order to kind of see, but usually there's no overlap between the two. Gadolinium has generally been shown to be very safe. There's really no studies that have shown any significant long-term problems with gadolinium, with a couple caveats. So one is that you have good kidney function. So similar actually to the contrast you get for a CT scan. If your kidneys are not functioning very well, it can make them slightly worse. So you just have to make sure you have good kidney function. It's not quite as dangerous as the contrast you get for a CT scan, but there is a little bit of requirement there. And the other thing that people frequently will read about is that the body is not entirely perfect at excreting or getting rid of all of the gadolinium. So there have been some studies that suggest that some of the gadolinium is retained in very trace amounts in different tissues of the body. And one of those places where we've seen that sometimes is the brain. Now, again, no study has shown that there's an increased risk of any neurological problems from the contrast, meaning like seizures, headaches, epilepsy, or even more chronic things like Parkinson's, dementia, Alzheimer's. None of those things have ever been shown to be associated with gadolinium use. So while those things are out there and it's good for us to be aware of them, it wouldn't prevent me from ordering or wanting somebody to have an MRI. The other thing to know about a breast MRI is it is very sensitive. And that's why we like it, right? So it's more sensitive than the mammogram. It's more likely to find cancer than a mammogram. It's more likely to find cancer at an earlier stage. And so that's why we often will recommend MRIs for high-risk women. The biggest downside to MRI in my mind is that it is so sensitive, but it's just not good at telling us what those things are. So it's going to find things, but it's not going to say, oh, that's a cancer, that's not a cancer. It's just going to say, I see something, and then you're going to have to get more workup. So that might mean more imaging. Sometimes it means biopsies. And, those things, as long as they turn out negative, aren't that big of a deal. But as I'm sure many people here had many tests before, there's always some anxiety when you have to have another test that's trying to rule out cancer, right? And so that anxiety sometimes can be uncomfortable, difficult, especially if you're getting this test every year. So it's just something you have to be aware of and, be willing to accept that if you decide to get breast MRIs. The only other test I wanted to mention is breast thermography. This is something that a lot of my patients will ask me about. It's an interesting tool. Unfortunately, it's never really been shown to be a good screening test for breast cancer. So I actually do not recommend thermography as any kind of replacement for whatever normal breast cancer screening you would get. So if you would normally get a mammogram or an MRI, please do not swap it out for thermography. If you want to get thermography, that's great. And you can do anything extra like that you want, but think of it as extra and not as a replacement. So just kind of in summary, some of the different breast tests, again, breast exams, ultrasounds, mammograms, MRIs, of course, that may lead to breast biopsies. And unfortunately, if you were to ever get cancer, it may lead to staging tests. So the last test, let's call it, that I want to talk about is what we call actually breast self-exams, or more commonly now is called breast self-awareness. So I don't exactly know how you're supposed to be aware of your breasts without examining them. So I still call it breast self-exam. But I think what they're trying to get away from is that there's some right way to do a breast exam. And if you don't do it that way, then you're not doing it right. So just know that the right way to do a breast exam is to do one. If you are doing one, you are doing it the right way. That's all there is to it. So there's no right or wrong way to do a breast self-exam. But there are some things to just know generally when thinking about a self-exam. So a couple pointers that I always tell my patients. So one is just know where there's breast tissue. So breast tissue can come all the way up to our collarbones and can be under the arm sometimes. And so that creates kind of like this box across your chest. And you just want to make sure that you check everything in the box. Okay, so check all the way up high on the chest, check all the way under the arms, and everything in between. And as long as you do that, you're covering all the breast tissue, or where there could be breast tissue. The other tip that I will tell women is that not all breast cancers are something you can feel. Sometimes it's something you can see. And so you have to look in the mirror. I know that's not everybody's favorite thing to do, but every once in a while, you need to take a look at the breast in the mirror, because you might notice something different, a puckering, a rash. The nipples are pointing in different directions now, and they used to do something else. So these things that are subtle aren't always something you can feel, but rather something you can see. When it comes to actually doing the breast exam, one thing that will help sometimes is trying to use the flat parts of your fingers instead of your fingertips. Fingertips are just really sensitive. And so if you use the very tips of your fingers, sometimes it's going to feel like you've got nothing but lumps in your breast, and that's going to make you really nervous. So you want to use kind of the flat parts of your fingers, and then just look for things that stand out. Generally speaking, cancer is going to feel really hard or firm. So it's going to feel like this wood that I'm knocking on. Okay, so firm like that. So if you feel something like somebody put a marble or a rock in your breast, that's going to be a little more concerning than something that's a little bit more like what we call rubbery. So it's like solid, but not quite like rock hard. But again, anytime you feel something, if you have any questions at all, you should always bring it to the attention of your provider, let them examine it, and most likely they're going to order some imaging. So again, don't let this stress you out. It shouldn't take you 20 minutes. You could do it in a minute, maybe 2 minutes. You can do it in the shower, laying in bed at night, have someone else do it for you. I mean, hey, whatever works, any of that is fine. Again, you just need to be kind of in tune with your body and know exactly, and know generally, I guess, what your normal is. And if something changes, you want to bring that to someone's attention. So that's just kind of some general guidance on breast cancer screening. The last thing I want to talk about breast cancer screening is how this applies to you. So coming back to this National Comprehensive Cancer Network. So again, they put forth guidelines mostly on breast cancer treatment and all cancer treatment, not just breast, but they also have some guidelines on screening. And in this guideline, they actually talk about people who've had thoracic radiation. So you can see here, this is the subset that I pulled out, literally cut and pasted from that guideline. And these guidelines suggest that people who've had thoracic radiation therapy between the ages of 10 and 30, and they are currently one of these two ages, this is how you manage it. So if that person is currently under the age of 25, they should have an annual clinical encounter beginning 8 years after radiation, and they should be doing breast self-exams or have breast awareness, as we've already talked about. Once that person or woman becomes 25, then the recommendations start to change. Then those clinical encounters need to be at least every year, but maybe every 6 months, starting again 8 years after radiation. And then we're going to add some things on top of that, including annual screening mammograms, tomosynthesis or 3D is recommended, again, starting 8 years after radiation, but not prior to age 30. And then we're going to start doing breast MRIs once a year, again, 8 years after radiation or no earlier than age 25. Can also consider contrast enhanced mammography or whole breast ultrasound if you can't do an MRI, and then consider risk reduction strategies, and we'll talk about what those might be. And again, the breast awareness. So I was asked about, the appropriate screening tests for women who've had Hodgkin's lymphoma, and it's really people who've had Hodgkin's lymphoma and had radiation to the chest of some type. And if so, you really should be getting high-risk screening, and this is the high-risk screening that I would recommend. Mammograms starting at the age of 30 every year, MRIs starting usually around the age of 25 or at least 8 years after radiation treatment completed, and doing those annually. And the way I usually do it is I alternate them every 6 months. So that way you're getting some tests every 6 months. So let's say today you had a mammogram, and 6 months you'd have an MRI, 6 months mammogram, 6 months MRI, 6 months mammogram, and every 6 months we'd be alternating between the two. And those are the current screening guidelines. So if you ever get any pushback, you can refer your provider, you can refer your insurance company to this nationally available data supported guideline. And if they go to this, they will get all the information they need. So again, focusing a little bit more on your population, on Hodgkin's lymphoma patients, I was asked to talk a little bit about breast cancer risk in this population specifically. So I thought about showing you some of the raw data that's been published, and then I thought, well, that's maybe not as helpful. But what that data has been used is to develop a calculator, which I actually think is pretty cool. So instead, I've decided to show you the calculator. So there's this website called the Childhood Cancer Survivor Story. Probably many of you are familiar with that. And on this website, they have a couple different calculators. You can see there's a cardiovascular risk calculator, which I know that the people here are at risk for cardiovascular disease. There's kidney calculator, acute ovarian failure calculator. And then, of course, relevant to today, there's a breast cancer probability calculator. So if you go here, the first question it says, I know this might be a little hard to read, but it says, do you have a history of breast cancer or double mastectomy? This calculator is only for people who've not had either of those things. So you've not had double mastectomy and you have never had breast cancer. So if I click no on that, then you're going to get this next screen and you're going to start answering more questions. So what is the patient's current age? What kind of radiation did they get? Did they get mantle field radiotherapy to part of the chest, mediastinal, whole lung, total body, or something else? Was chest radiation given within 1 year of the patient's first menstrual period, and were anthracyclines used? So you just pick whatever answers are relevant to your patient. And then on the next screen, it will say, is the patient's current menopausal status? Never had a period, postmenopausal, or they stopped before 25, postmenopausal, meaning periods stopped between 25 and 34, or after 35, or they're still menstruating, or unable to tell because they've had a hysterectomy. And then the last question is, have any of the patient's first-degree relatives been diagnosed with breast cancer? So once you've answered all those questions, you hit the calculate prediction button there at the bottom, and the risk estimate comes up. So for my pretend patient here, you can see that the estimated risk of developing breast cancer in just 5 years is 15%, and over the next 10 years is 24%. So now again, going back to those average risk women, remember I told you that 1 in 8 women will develop breast cancer on average. So that average risk over a lifetime, not 5 years, not 10 years, but lifetime, is about 12%. So you can see that this make-believe person I've just put together, her risk in the next 10 years is 24%. So quite a bit higher than the average risk woman's risk. And that's why we do recommend high-risk screening, because we know that your risk of developing breast cancer is higher. And so we want to watch you more closely. Again, thinking about those risks and benefits, and probably for patients like you, the benefits are going to outweigh the risk, because again, we want to catch things as early as possible. So what do you need to know? Well, you really need to just remember a few things. Not all women are the same. Not everyone's risk of breast cancer is the same. So every woman needs to understand her breast cancer risk and have breast cancer risk assessment. Even in your population, you can see that there's a calculator that's specific to Hodgkin's lymphoma patients who've had radiation. And I can kind of personalize your risk estimate based on that calculator. Now, it's not perfect, but it will get us kind of in a closer ballpark. So, make sure that you know your risk and know that you have options. So now we're going to talk a little bit about what breast cancer is. Just a couple quick slides. Again, many of you are probably familiar with this, but for those of you who are not, I hope this is helpful. Starting with a little bit of breast anatomy, which we'll come back to when we talk about surgery in a minute, but breast tissue is mostly made up of fatty tissue. Within that fatty tissue, you have mammary glands or lobules that make breast milk, and that breast milk travels down these milk ducts and out the nipple, and that's how breastfeeding happens. So if you think of that milk duct like a tube or a pipe and you cut it on end, it looks something like this. On the far left, you see a normal duct that has a nice, normal, neat row of cells. And this is kind of what one progression to cancer might look like. The cells start to increase in the layers. The cells look a little funny, eventually turn into cancer. And then those cancer cells burst out or invade outside of those milk ducts. And that's when you've developed invasive breast cancer. So there are a lot of different ways to classify breast cancer. I'm going to go through just some of the more common ones. So first, we usually start off by saying, is the cancer invasive or in situ? In situ cancer means that those cancer cells are inside the milk ducts. So that's the second from the right, DCIS, ductal carcinoma in situ. So you can see here, these cancer cells are inside the milk duct. And then once those cancer cells get outside of the milk duct, that is what makes it an invasive breast cancer. So we've got ductal versus lobular, meaning did the cancer start in the milk ducts or in the milk globules? Then we've got grade, and grade is different than stage. Grade is what does your cancer look like under a microscope? And here we've got the 3 different grades. Grade 1 means it looks a little bit still like normal breast tissue. And then you've got grade 3, which means it just looks like cancer. And then grade 2 is something in between. And there's a scoring system to determine what grade your cancer is, but this is just something you'll hear them talk about if you're ever diagnosed with breast cancer. Then one of the things that's most important these days are the receptors. So there's 3 important receptors in breast cancer. There's the estrogen receptor, which responds to estrogen, the progesterone receptor, which responds to progesterone, and then there's a third one called HER2, which is a protein that we see on the breast cancer cells. And when you have it, you can see on the far right, you can see a bunch more of those little green receptors on the cell, meaning it has lots of HER2 expression. Then we can talk about stage. Now, stage these days has gotten really complicated because it's a combination of so many things. It used to just be what we call the TNM, which is the tumor size, the nodal status, and whether or not you have distant metastasis. But now we also include those receptors we just talked about, the tumor grade, some genetic tests of the tumor are included, and then this gets broken out into a stage 1, 2, 3, or 4, and there's even subdivisions of that. There's actually a 1A and a 1B, a 2A and a 2B, etc. But generally speaking, the TNM, again, T stands for the tumor size. A smaller tumor is a lower T. A bigger tumor is going to be the T4. If your lymph nodes are negative, it's an N0. And the more lymph nodes you have, you get the N1, N2, N3. And then, of course, the M is metastasis, meaning it's spread somewhere outside of the breast and the local lymph nodes. So let's talk again a little bit more about our Hodgkin's patients. So how does radiation cause breast cancer? Because it's not actually the Hodgkin's that causes it. It's the treatment that you got for your Hodgkin's, which you thought was helping you, right? It's curing one cancer only to then cause you other problems. I've been hearing about the vocal cord troubles, some dental and jaw problems. And of course, breast cancer is just another one of those things that changes when you've had this radiation. So essentially what's happening is if this healthy cell gets this ionizing radiation, it's causing genetic damage or DNA damage. And that DNA damage turns that cell into a cancer cell, and then that cancer cell proliferates or grows, and that's where your tumor is coming from. So just to break it down a little bit further, in a normal cell, if it gets cell damage and it's not repaired, usually that cell will die or be killed. And so we call that apoptosis, meaning that cell just goes away. But that isn't always the case. Sometimes that cell will proliferate or grow. And that one mutation or one area of damage sometimes isn't enough to really to cause any big problems. But then that cell gets another hit, is what we call it, and then another hit, and then another hit. And by the time you get to the 3rd and 4th hit, or the mutations in those cells, then that cell gets growing out of hand. And that's really when that tumor develops. So essentially what it's doing is it's accelerating the process of developing cancer. So just to break it down a little bit more simply, think of your body like a copy machine. So you're born with a certain set of cells, and every day, every minute of every day, your body is making copies of the cells that it has. So those old cells die and you make new ones, and the new ones are copies of the old ones. And just like a copy machine, sometimes mistakes are made, right? So if you think of taking a piece of paper and you make a copy of it, you'll notice that after a few copies, there might be a streak on there, right? I know the body's pretty good. Most of the time it sees the streak, it erases it, and you got a nice clean copy again. But sometimes it doesn't, right? Sometimes that mistake doesn't get caught. And then if you make a copy of the one with the streak, that streak gets worse. And then you got another streak on there. And if you make a copy of that one, now you've got a third streak. And it just kind of compounds on that. And that's eventually how you develop cancer. So essentially what's happening in people who've had radiation is you're starting that change, that streak on the paper at a much earlier stage than people who've not had radiation, because you're putting that first mark on the paper. So you're already like on your way to developing breast cancer when you get these really high doses of radiation that are meant to be therapeutic. Unfortunately, they can also cause some problems, as many of you have discovered. So how is breast cancer treated? So it's a team approach, right? I like to put a little music in there to make sure everybody's awake. So it's a team approach, right? You're going to see a multidisciplinary clinic in breast, probably similar to how Hodgkin's is these days. At least I know here at Duke, you'll see lots of different providers. Of course, the patient at the center of it all, but for breast, you're going to see a surgeon, probably a medical oncologist, radiation oncologist, maybe a reconstructive surgeon. But then also on that team, we have the people that you may not see. We have the pathologists, the radiologists, the genetics, nutrition, psycho-oncology, physical therapy, pharmacists, nursing, and social work. So there is a huge team that comes together to help treat women who develop breast cancer. So what are some of the issues you have to consider when treatment planning? So of course, we're going to talk more about surgery here in just a minute, but from a surgical standpoint, are we thinking mastectomy, breast conservation? What about the other breasts? What do we do with these lymph nodes? Do they need reconstruction? Then there's systemic therapy considerations. Do they need chemotherapy? Do they need targeted therapies? What about endocrine therapy or the hormone blocking medications? Radiation therapy. Now, many of you have had radiation therapy. So are you a candidate for radiation again? And do we radiate the breast? Do we radiate the lymph nodes? And then, of course, the question of, do you need genetic testing? So again, you're talking to the surgeon today, so I'm going to largely focus on the issues to consider for surgical planning. So when it comes to surgical planning for Hodgkin's patients, I want to be thinking about their medical history. I want to be thinking about what kind of lymphoma they had, or the timing of the Hodgkin's lymphoma. What kind of treatment did they get for their Hodgkin's lymphoma? Did they get radiation? Did they get radiation plus chemo? And what fields were radiated with the radiation? What kind of current medical problems do they have? Are they having trouble with their voice? Have they had jaw problems? Do they have cardiac problems? Do they have a low ejection fraction? Do they have lung problems? Do they have, fibrosis of the lungs? Do they have, asthma? What kind of things are they having that probably aren't that common otherwise? What other potential complications do I need to be thinking about? Are they going to be at risk for wound healing problems? And then last but not least, we have to weigh all these risks and benefits, right? So if you have, all of this constellation of things, but this is the potential benefit, how does that really shake out for the person in front of me? So the main thing I think I want to talk about today is breast surgery. So again, happen to be a breast surgeon, so this is my specialty, my area of interest. And I just want to talk a little bit broadly about breast surgery, and then we'll kind of focus it down again to your population. So why do people see a breast surgeon? So this is the Duke team at one point in time. There's been some changes, but generally this is many of us. You might see a breast surgeon for benign breast problems, so not cancer. You might see them because you have breast cancer. And of course, many breast surgeons like me have an interest in breast cancer risk. So what kind of things does a breast surgeon do? Well, we do diagnostic surgeries, we do therapeutic surgeries, and we do prophylactic or risk-reducing surgeries. So what goes into each one? So diagnostic surgeries might be because you have a rash or nipple discharge or a mass. You might have something abnormal on your imaging, on your mammogram. You might have calcifications, distortion, asymmetry, or mass. And some of the pathology findings might be things like a fibroadenoma, a cyst, a papilloma, or breast atypia. When it comes to therapeutic surgeries, again, exam findings, meaning on your self-exam or on the clinical exam, you might have nipple discharge or a mass. Imaging findings can be very similar: calcifications, distortions, asymmetry, or masses, and this could be related to breast cancer. Of course, then the one we'd like to talk a little bit more about today, risk-reducing surgery. So how do we prevent this? And who's going to be getting these risk-reducing surgeries anyway? So probably the most common population I do this in, probably because they're the most common, are going to be germline pathogenic variants. So people who have things like those BRCA mutations that you've probably heard a lot about, they commonly will opt to have these prophylactic mastectomies to help lower their risk of breast cancer. Again, just for perspective, women who have a BRCA mutation, their lifetime risk of developing breast cancer is thought to be around 70%. And actually, interestingly, there have been some studies to suggest that depending on the type of radiation that you've had and the age you had it and some of the other things, people who've had Hodgkin's lymphoma with various treatments might have a risk over their lifetime that is actually very similar. And so for me, it makes sense, as you can see here, it's another group that may consider risk-reducing surgery. So how do we do these breast surgeries? So to understand breast surgery, I think first we have to go back to our anatomy. So remember, the breast is sitting on the chest wall on top of the muscle. So you have the chest wall muscle, and on top of that, you have this breast tissue, again, that's largely fatty, but it has all this glandular tissue in it, meaning the milk ducts, the lobules, etc. So when it comes to removing parts of the breast, there's a few different categories it'll fall into. So for the breast, we can talk about lumpectomies or excisional biopsies, and then we'll talk a lot about mastectomies. And then, of course, you can't talk about breast cancer without talking about what to do with the lymph nodes. So let's start with kind of the lumpectomy surgeries. So a lumpectomy has lots of names. Could be a partial mastectomy, a quadrantectomy, an excisional biopsy. If you can feel the lump, you just take out the lump you feel. If you can't feel it, sometimes you have to localize it or put some device in there that helps tell you where the area is. And then sometimes this is done with lymph node surgery if it's done for cancer. So sometimes we will localize the area with a wire. So this is a mammogram in the side-to-side squish view. And you can see right in the middle of that mammogram, there are these little white dots. Those are called calcifications. So those calcifications maybe represent cancer, let's say. And so we put this wire in the breast, and it's kind of showing me exactly, kind of like an arrow pointing to where it is. So I know this picture has an actual arrow. That's the bigger one. The little skinny thing here is the wire, and you can see it's right next to the area of interest. So to do this surgery, you make an incision on the breast, and then you literally just kind of cut around the wire. It's as simple as it sounds. It's pretty straightforward. Once you take the specimen out, it might look like this bottom right-hand picture, and then we take an x-ray of it just to prove that we can see here some calcifications are indeed right next to that wire. So I was able to take out what I meant to take out. The more common way that I do this surgery these days is with a seed localization. So there's this little radioactive seed, which is literally about the size of a grain of rice. We put it into the breast, and then we remove it. So again, it's really small. This is a dime. So you can see how small it is compared to a dime. You can see it on this person's finger. So a teeny, teeny, tiny little marker that gets put in. It's about the size of the biopsy clips that get put in, maybe just a hair bigger. And we identify this because it's radioactive. So we use a gamma probe, which this is the detector here. And then you can see these things that are kind of pencil-like. Those are the gamma probes. And it's kind of like when people have those metal detectors, right? Where you go out and you're like scanning the beach looking for gold, and you just kind of scan things. That's exactly what I'm doing in the operating room. And as I get close to the radioactive seed, the machine will go beep, 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 beep. And that's how I know that I'm at the area that I need to remove. So again, I might take out a lump that looks like this. You do the x-ray, and you can see here this little marker with the pink arrow. That's the radioactive seed, so I know I took out the right area. When it comes to having lumpectomies, some women are concerned with kind of the appearance of the breast after surgery. And so we always want to think about where's going to be the best place to put the incision. So around the areolar border is a very popular place. And you can see in this real life picture here that it hid that scar really well. But of course, you can put the scar almost anywhere on the breast. So I often will like to put it down here under the fold of the breast. And you can see in this bottom right-hand picture, even though it's on a more top side of the breast, so perhaps a little more visible, they were able to tuck it in her tan line. So it was underneath the swimsuit. So even though potentially visible, very well hidden by her swimsuit. So lots of different ways to think about how to hide these scars. Some people also have a breast reduction when they have this lumpectomy. So this is just an example of what that looks like. You can see the lump here in picture A. Then you take out kind of that tissue and close things up. And then this is kind of what a final outcome might look like after a breast reduction. So let's shift gears to a mastectomy, because many of you are probably not going to be great candidates for a lumpectomy, because in order to do a lumpectomy for breast cancer, it needs to be accompanied by radiation. And many of you will have already had radiation, and we generally don't like to radiate the breast more than once. That being said, there are some studies that have looked at re-irradiation of the breast tissue, but generally speaking, we don't love to do it. So many people who've had radiation are going to be looking more at the mastectomy side of things. So there are a few different types of mastectomy. Again, the goal being to remove all or most of the breast tissue. And again, it's going to be kind of sitting in front of that pectoralis muscle, but can come all the way up to our collarbones and can be underneath the arm. And when we remove the breast, we remove it what I call en bloc, meaning all of it comes off at once. So sometimes people ask me, did I see their cancer? And the answer is no. If I saw your cancer, then I was way too close to it. I want to have lots of tissue all the way around it so that you have negative margins. So you remove everything all in one piece. So thinking about the different types of mastectomy, there's total mastectomies, there's skin sparing, nipple sparing, and then something called a modified radical. And we're going to break that down a little bit. So a total mastectomy means removing all of the breast tissue, including the nipple areolar complex and a lot of this overlying skin. This can be done with or without lymph node assessment, and it usually is implying that they're not having reconstruction. And this is an example of what a total mastectomy might look like after they've had surgery. So a skin sparing mastectomy is exactly what it sounds like. You're removing all the breast tissue, but leaving behind the skin. You are going to remove the nipple areolar complex for this, but again, leaving behind that skin envelope that kind of was holding the breast prior to the breast removal. This can also be done with or without lymph node assessment, and it usually means the patient's having reconstruction. And reconstruction comes in a bunch of different types. It can be with a tissue expander or with an implant or with your own tissue. And again, that's a conversation you'd have with a plastic surgeon. And this is an example of somebody who had breast reconstruction with implants and a skin sparing approach. So you can see she no longer has her nipples, but she certainly has a normal amount of breast tissue or breast volume after the surgery. So then last but not least, we have the nipple sparing mastectomy, which means we not only save the skin, but also the nipple itself. So for this surgery, again, you're removing just the breast tissue, but none of the skin or the nipple. This can also be done with or without lymph node assessment. And again, it usually means you're having reconstruction of some type, whether it be with a tissue expander, an implant, or a tissue flap. And this is an example of what that might look like. So this woman has had a nipple sparing mastectomy. She's opted to have slightly larger breasts, but you can see a very nice cosmetic outcome. The last type of mastectomy I wanted to mention just real quick is it can be really done with any of the three things I've just said, but usually means that you're not having reconstruction. And by definition, it means you're having many of those lymph nodes from underneath your arm removed. So a modified radical means mastectomy and axillary lymph node dissection. So remember I said all those other mastectomies, you might have lymph nodes removed and you might not. But for this term in particular, this is defined as having a mastectomy with an axillary dissection. Most of the time it's done without reconstruction. So just real quick talking about the lymph nodes for people who have breast cancer, usually we're going to want to check the lymph nodes, and there's a couple different ways we can do that. We can do a sentinel lymph node biopsy, we can do a targeted axillary dissection or a directed sentinel lymph node biopsy, and we can just do a traditional axillary lymph node dissection. So a sentinel lymph node biopsy, a little more about that. So all people pretty much have sentinel lymph nodes. All that means is those are the lymph nodes that are the primary draining lymph nodes of the breast. So you have lots of lymph nodes, but there's some primary ones, and then there's the other ones. So finding or removing them does not mean that they have cancer in them. The number of sentinel lymph nodes that everybody has is different. I might have 1, you might have 5, somebody else might have 3. All of that's normal. It's just normal variation between different people. But most people have somewhere between 1 to 5. And most women have about 30 to 40 lymph nodes total underneath your arm. So how many of them are sentinel? Again, about 1 to 5. So not very many of them are what we would consider sentinel. So how do you find these lymph nodes? So it can be done with any type of breast surgery, but it does require the injection of a tracer. So there's 2 main types of tracer. There's a blue dye that gets injected to the breast and it turns the lymph nodes blue. And there's a radioactive one that then makes the lymph nodes radioactive. Sometimes it requires a separate incision at the time of surgery, but just depends on what kind of breast surgery you're having. So radioactive is probably going to be the most common way to do this. So again, you inject with this radioactive dye, it goes to the lymph nodes. And then as I use that gamma probe that I showed you earlier, as I get close to that lymph node, just like the seed, it's going to go beep, 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 beep. And that's how I know that that lymph node is the sentinel node that needs to be removed. So for an axillary lymph node dissection, this is traditionally defined by anatomy, meaning there are anatomic borders that define what you need to take out. And those include a couple different major things like the axillary vein, your pectoralis muscle, and the latissimus dorsi. And it usually includes 2 of the 3 levels of lymph nodes under the arm. So under the arm, there are what we call 3 levels. So there's, again, remember 30 or 40 lymph nodes, and they kind of divide them up into 3 chunks. And we remove essentially 2 of the 3 chunks of lymph nodes. And you can see those here highlighted underneath the arm. Again, it can be done with any type of breast surgery, does not require use of any of those tracers, radioactive or blue dye. It does sometimes require a separate incision, particularly for patients having a lumpectomy. So again, coming back to your population, so risk-reducing surgery. So why would we be doing prophylactic or risk-reducing surgery, and does that change anything? Well, the goal is to reduce your risk of breast cancer. And most studies, even in Hodgkin survivor populations, suggest that it will reduce your risk by 90 to 95%. So again, if I say your lifetime risk of developing breast cancer is, let's just say 50%, I can then do these mastectomies and I will make your risk less than 5%. And that's a pretty good reduction. You'll notice I didn't say zero though. There is nothing I can offer you to make your risk of breast cancer zero, not even removing both breasts. But why is that? Well, again, it has to do with the anatomy. So if we say this is our breast tissue here, you can see there's lots of things that are in that breast tissue. But one of the things that's not shown here is the blood supply to the skin and the nipple. And that blood supply actually comes from two places. Some of it comes through the breast tissue itself, and some of it is actually running right underneath the skin. So when I remove the breast tissue, I remove most of the blood supply. So then the only blood supply left is the blood supply with the skin. And if I get too close to the skin, that will damage that blood supply. And then you'll have no blood to that skin. And instead, what will happen is that skin will die, and then you have a big hole in your chest, which is obviously not what we're going for. No holes anywhere. So you do have to leave some tissue right underneath the skin. And as you can see here, that breast tissue gets kind of close to the skin. So if I'm leaving behind tissue, it is very possible, in fact, likely, that I will also leave behind a little bit of breast tissue. And that's how you can still get breast cancer even after a mastectomy. So how do you make these decisions? So first you have to decide, is it right for you? So you'll notice if we go back to those guidelines, it does not say you have to have mastectomies. So you do not have to have mastectomies. I don't care what anybody says, you don't have to do it. Nobody's coming to your house and dragging you to the operating room. But you have to decide, is it right for you? So someone will say, I don't want a risk of 50%. I like what she said about 3 or 4%. That's what I want. I want 3 to 4%. And so for you, it might be the right decision. And if it is, then the next thing you have to decide is whether or not you want reconstruction. If you don't, great, you'll just be flat. And if you do, then the next step is to meet with a plastic surgeon. And of course, the last decision you'll have to make is the timing. Is now the right time, or is this a really bad time? You know, you just got a new job, you just had a new baby, you just got married, you moved. I mean, whatever else is going on in life, is now the right time to do it? And only you can answer these questions. And so you have to really be thinking about these risks and benefits of surgery. So surgery is surgery, right? There are definitely going to be complications. And is now an okay-ish time to have to deal with that, or whatever comes up? I mean, no time's going to be perfect, but certainly some times are going to be better in life than others. And so you just have to weigh those for yourself. Will these benefits outweigh the risks? When it comes to deciding about whether or not you want to have reconstruction or just be flat, it is entirely 100% a personal choice. So you do not have to have reconstruction, but certainly most women are candidates for it. So if you want to have it, again, what kind you have may or may not, everyone may not have the same options, but most women have some options. And that would be a conversation between you and a plastic surgeon. Again, there's no right or wrong timing to this surgery. You might want to have it now, you might want to have it later, you might never want to have it. It is an entirely personal decision about whether or not you want to have surgery, and if so, what the timing of that is. So that's what I had for you today. So I'm going to go ahead and stop sharing my screen. I see there's some things going on in the chat. So I don't know if Erin or Rachel wants to walk me through questions you want me to talk about.
Sure, that'd be great. Rachel, are you with me?
Yes, I am.
Okay, why don't we take it from the top? I think Alyssa had a question. Can you read her question, Dr. Plichta?
Let me see.
I'm going to have Rachel read it out loud since her voice is a lot better.
Okay, is it the I've been diagnosed with breast cancer
Yes.
one?
Yep.
Okay. Yep. So I can't give out medical advice to anybody. So let me just read this question and see if I can talk about it in generalities. So let's see. So I've been diagnosed with breast cancer in April at age 41, got a mastectomy, but nothing on the right side. And I am fighting to find a specialist doctor able to answer me about my risks and what to do. In Italy, mastectomy is only allowed if you have BRCA1 or 2. I've been given tamoxifen. I'm scared it is the right cure since no oncologist was able to answer about my interaction or side effect for me. I'm very anxious. I'd like to know if I am my right way since I feel left to myself.
Yeah.
20 years off therapy. Okay, so again, I can't give anybody medical advice. So let's just talk a little bit about generalities for breast cancer risk. So again, your risk of developing breast cancer is quite high. There are not great studies talking about second breast cancer risk. So while there are plenty of studies that show that you have this increased risk of breast cancer, once you have it, there's not great data on developing breast cancer, say, in the contralateral or the opposite breast. That data does exist in other populations, though, and we can assume that it probably mirrors your population. So in general, if you have a BRCA mutation, again, that woman's risk of breast cancer is about 70%, and her risk, if she gets breast cancer the first time, of getting it in the other breast is probably somewhere between 30 to 50%. I usually tell people it's in the 30 to 40% range, so let's just say half of 70. And we see kind of the same thing in average risk women. So average risk woman's risk of breast cancer is about 12%. Her risk of getting breast cancer on the other side is probably about 6 to 8%. So again, about half. So if I say your risk of getting one breast cancer is 50%, your risk of getting in the other breast, I think a reasonable estimate would be 25%, just kind of extrapolating from other populations. When it comes to tamoxifen and Hodgkin's lymphoma patients, there's not been a lot of great data to support it, but I do say that it has been shown to reduce, in general, women's risk of breast cancer, and it is very effective. It can reduce your risk of breast cancer by about 30 to 50%. And again, that's for women who've never had breast cancer. In contrast, it's also used to prevent recurrence. So people who've had breast cancer, if it's hormone receptor positive, they will be given these types of endocrine therapies like tamoxifen, aromatase inhibitors, and it will not only prevent new breast cancers, but prevent the first one from coming back. So it serves kind of a double purpose. It actually treats both recurrence risk and risk of developing new breast cancers. The other thing I will say, and I didn't get into it here, but Hodgkin's lymphoma patients do have a tendency to develop kind of run-of-the-mill breast cancers. So they tend to get the hormone receptor positive breast cancers. So in my mind, it makes sense that endocrine therapy can help reduce risk of breast cancer, even in patients who have Hodgkin's lymphoma, because the types of cancers they tend to get are these hormone receptor positive ones. So if we can kind of, block those receptors, in theory, it should also reduce that risk. So again, I know I can't speak specifically to this case because I can't give medical advice, but hopefully that gives you some generalities that might be helpful for you to think about.
Just as a quick, Lisa had a follow-up question about not being able to discuss the options of mastectomies. And I guess that's particular to her situation in Italy. And I know you've stressed that everybody's situation is different, period. But do you, as a surgeon, have you had the experience of, as some of us had, of other physicians and surgeons being somewhat reluctant to discuss prophylactic mastectomies with their clients?
Yeah, absolutely. So there's a couple things that go into it. So one is that not everybody feels as comfortable with discussing breast cancer risk, right? Like, this is my specialty. It's not everybody's specialty. You would think we're all breast surgeons. We should all know the same things, but we don't. We do have like sub-specializations in there. Now, thankfully, it's not so specialized that I'm like, I only operate on the right breast, but not the left. But there are different specialties, and not everybody feels as comfortable, particularly with the Hodgkin's population, because it is actually quite rare. Even though I see, hundreds of high-risk patients every year, I don't actually see that many Hodgkin's patients each year. And I see more than anybody else here at Duke because this is my specialty. So I can imagine that my colleagues probably don't feel as comfortable with it. So that's problem number one. Problem number two is that there's really not great data to say that having mastectomies will help women live longer. And that is where we're getting into a lot of debate about who should be getting mastectomies, preventative mastectomies, because people are of the mindset that if it's not going to help people live longer, then maybe we shouldn't be doing it. But for me, it's a personal choice. So I may not be able to help you live longer, but I can prevent you from having to go through it. And a lot of women choose that. They say, well, yeah, I just assume not have cancer. Even if it's not going to kill me, I just rather not have it. And that's kind of the decision that you're making. There's a little bit of data in the Hodgkin's population that mastectomy, again, will lower your risk of breast cancer, but not really data to say that it will help you live longer. And even in BRCA patients who have the highest, most published high risk, even in that population, there's very little data to say it will help those women live longer. And they're the most common ones having these mastectomies. And so that's where a lot of the pushback comes from, is that this debate about is there having no survival benefit but there's a risk of, incidence. Is that enough to be offering these preventative surgeries? So I think those are probably the two main problems that people face when discussing with your physician.
Just as another quick follow-up to that same thing, one of the things that we've been hearing over the years is that it's not just the risk of being diagnosed with breast cancer, it's that our treatment and surgical options might be more limited than it would be for another person. Is that true in your experience?
Yeah, also true. So like I mentioned earlier, a lot of people are reluctant to re-irradiate people who've had radiation therapy to the chest. So that does limit, your options there. If you're having any of those cardiac toxicities from the chemotherapies you might have had, then they might limit your future chemotherapy options. Now, that being said, more surgery is not going to help you, get a different chemotherapy regimen. But, I think that it's something we can think about. The other thing that goes into it is, most of the time, I meant to mention this earlier, so it's not specific to the question you just asked, but since I thought of it and I'm going backwards, there's also never been a study that's looked at high-risk screening versus preventative mastectomies. So there's really no study that says that your outcomes will be better or worse if you have mastectomy versus high-risk screening. So that also comes into play. Again, I might be able to prevent you from going through it, but if we can catch it early enough, it may not change much from a treatment standpoint. So in that sense, maybe it does apply that I might be able to catch it early enough that we won't even have to consider some of these chemotherapies that might be more dangerous than you because of the things you've already had.
Mm-hmm. Gotcha. Great. Go ahead, Rachel.
There's a good question here from somebody that I think several of us probably have some similar version of. Mandy wrote, I was diagnosed with breast cancer in the left side in October 2020, chose prophylactic removal for the right, had a double mastectomy with aesthetic flat closure. How do I self-check now? Yep. And there's a question for anybody who's had reconstruction or not reconstruction, has had both breasts removed. Do we need mammograms? Do we need MRIs? How do we self-check?
Yeah, so self-exam is the same no matter if you have lots of breast tissue or almost no breast tissue. So the same things I talked about, on that slide that showed self-exam, all the same tips. You have to look in the mirror, check everything in the box, use the flat parts of your finger. Do it regularly enough that you know what your normal is. Now that means once a week, once a month, every other month, however often you need to do it to kind of know you. It's the same rules apply whether you've had a mastectomy or not. From an imaging standpoint, most guidelines, in fact, pretty much all that I'm familiar with, or most of the major ones at least, maybe not all, but most of them suggest that you do not need any imaging. So there's no routine imaging, meaning mammogram, MRI, ultrasound, whatever, after you've had bilateral mastectomy, whether you've had reconstruction or not. Now, some people who've had implants might get breast MRIs to check the integrity of the implant, but there's no imaging screening for what residual breast tissue might be left behind. And the reason for that is because that risk is so much lower. Remember, we're talking your risk is going to be in the low single digits now. And so for those average risk women who were 12%, remember those guidelines barely recommend a mammogram once a year, and you are now less than half of that risk. So you can imagine it's not really great to screen for something when that risk is so low. So screening imaging is not recommended. But that being said, going back to the anatomy picture, remember I said if breast tissue is left behind, most of the time it's at the level of the skin, which means that it's going to be very superficial. So it's very easy to find and feel on exam, whether that's self-exam or exam by a provider. And so that's why those exams become very important, both that you are familiar with yourself and that you do get a breast or a chest wall exam at least once a year, because there's none of that routine imaging.
Great.
Dr. Plichta, I know that you said you needed to leave at 2:00. Do you want us to let you go, even though we don't want to? But if you need to go,
stay for like 5 more minutes, if that's helpful.
Perfect. Okay. Yeah.
I've got one question that is that Paul left me before he took off. Can you discuss male survivors of Hodgkin's and breast cancer risks? We don't talk too much about the men, so. As
you can imagine, there's not a lot of great data on this topic in general, and there's certainly no large studies that I'm familiar with for male Hodgkin survivors who've had radiation and breast cancer risk. Now, that study might exist, doesn't mean it doesn't, it just means I've not seen it. But again, if I think about extrapolating the data we do have, right? So generally we say, you know, if you've had Hodgkin's with radiation, your risk goes from that 12% to, let's just say, 50%. So a man's risk of developing breast cancer is about 1 in 800. Okay, so like less than 1%, right? Point some percent. So even if I, you know, times that by 10, that gets me up to what, 1%, 2%? So still very, very low risk, even though much higher than average, still pretty low risk. And so usually for men, I'm not familiar with any other additional, you know, guidelines that would be different for them about, you know, imaging or prophylactic surgeries or anything like that. I think really for them, it's going to be self-exam as well. Or clinical exam.
There are a couple of quick ones. There's a lot, but we can always maybe forward questions to you and have you address them at a later time. But there's a couple of ones that I think are going to be familiar. One is Carol's question down near the end. Rachel, if you want to read that about having a false negative on an MRI, can you see that?
Oh, yes. Okay. This is the question. I had IMRT chest radiation in 2011 for stage 4 Hodgkin's. I currently get high-risk screenings, the mammos and MRI every other 6 months.
Yep.
Oncologist has said I made it out of the highest risk window post-radiation. Is the window breast cancer risk highest in the first 10 years post-chest radiation exposure? I've had 2 false positives on MRIs. I'm on the fence about preventative mastectomy, but the screenings are hard to deal with. I agree with you. One physician suggests it may give me some peace of mind, while another says she would never recommend it. Do MRIs ever stop for high-risk women?
Yeah. So I showed you exactly what the guidelines say, and you'll notice they did not have an upper age limit. So there is no guideline that says stop at a certain age. There is data to suggest that divergence of risk is highest in the first, it's not 10 years, it's more the first couple decades, but let's just say you're now like 70 and you've not gotten breast cancer, right? And your treatment was when you were 15. Your risk is increasing at the same rate probably as an average risk woman at that point, if that makes sense. So you've already so like if your curves are starting out like this, you know, when you have Hodgkin's, they split, but at some point that difference stays then the same. Does that make sense? So like the slope of the curves are more parallel. So I do think that there is probably a point when you can stop MRIs. In the BRCA population, that cutoff is usually about age 75. And again, those are our highest risk patients. I would imagine in Hodgkin's, it can probably be lower, but it's going to have to be a personalized estimate, right? So, I mean, if you had your Hodgkin's in your mid or late 20s, that's going to be different maybe than if you had it when you were like 10 before your first period, or, you know what I mean? I think it's highly variable. So there's no like set cutoff in Hodgkin's on when to start MRIs. And I'd say that the same thing about risk, right? So the risk calculation is going to be a little bit different. You can try out the calculator that I showed you, and it can show you kind of what is your 10-year risk of developing breast cancer. And if you feel like that risk is high enough to do something preventative about it, then that's a personal choice. You know, you just have to find the right people that are kind of listening to what your concerns are and help you kind of weigh those risks and benefits. Mastectomies are certainly not for everybody, but they are helpful for some women. And, you know, really only the patient can decide that for themselves.
Maybe just as one last question from Sophia, the different focus, but regarding, she asked whether we should be concerned that insurance may begin denying coverage for breast MRI based on a recent Stanger publication in 2022. He found that MRI was not cost effective for Hodgkin lymphoma survivors. Any thoughts on that?
Yeah, I hadn't seen this publication. I'm going to open it up so I can look at it after this. But I will say the same thing has really been shown in lots of different situations, that MRI is a very expensive test. And so they are looking at ways to improve it. And again, this goes back to the types of breast cancer that Hodgkin's patients get. So there are other populations who are also high risk, kind of the atypia populations, where breast MRIs have similarly been shown to not change oncologic outcomes, meaning the stage of cancer that you're diagnosed with on MRI isn't dramatically different than the stage you might be diagnosed at on mammogram. And so they've shown, that maybe MRIs are not worth doing. But that being said, I think that every study pretty much will show that it will be diagnosed earlier, almost always on an MRI than it is on a mammogram. But it's the trade-off, right? That you're also going to find the other things and get the other biopsies. And so, these are some of the things when it comes to cost that you have to consider. So the cost of the extra imaging, the cost of these biopsies that all turn out to be benign versus I might catch your stage 1 breast cancer at 1 centimeter instead of 1.5, but both are considered stage 1. Right. So it's not changing kind of the oncologic diagnosis or outcome because I'm still catching it at stage 1, let's say. So that gets to be a little bit tricky. Generally speaking, guidelines don't tend to shift a whole lot with cost analyses. It can sometimes affect insurance opinion a little bit, but I haven't even seen that a whole lot. The insurance tends to rely on the national guidelines, and the guidelines, while we tend to consider cost, we tend to think more about what do we think is medically right or indicated for the patient and base the guidelines on that and less on, its financial impact to society. I don't know if that's right or wrong, but that's generally how guidelines go.
Well, it's a good question and maybe a good place to end in that. I think one of our struggles in the group is, hold on, let me just finish.
Okay, go ahead.
One of our biggest struggles as a group is to have physicians and primary care physicians in particular believe us and recognize and respect the fact that our needs and challenges are different from normal patients. And our worry has been that if a particular physician deems it unnecessary, that this is extra screening that he or she doesn't believe we need, then that might affect the ability to recover from insurance. So I think a lot of it feeds into the whole issue of cancer survivors in particular and what their challenges are going forward in terms of late effects.
Yeah, well, I think you can always point them to the NCCN guidelines, which are pretty vague, right? It has no cutoff for the MRI. So you can just say, there's this NCCN guideline that says I need an MRI. So if you feel like that's what you need to be doing, then you can point your insurance company or your provider or whoever to that and say, there is national guideline for this. So
good.
Good.
Okay, one last question I guess we got from
question real quickly, because I think several people have this question. Can you speak at all to the health of tissue post-radiation? Is that a consideration?
Yeah. It's really funny to me because, people who've had radiation exposure have beautiful mastectomy planes. I mean, that breast just comes right off of there. I mean, it is just one of my favorite types of mastectomy to do because the tissue is definitely different. The blood supply is a little bit compromised, and the glandular tissue is usually pretty involuted by that point. So it's actually a really easy case. They tend to be a little faster for me. The other problem, though, is that they're a much higher risk for seroma formation. So because of the change in the tissue, it doesn't stick down. So you can imagine if I create this big hole by removing the breast, the skin does not like to stick down to that chest wall because of these wound healing problems. So they don't I've not had a lot of increased risk of infection, but I've had a lot of seromas, meaning I took the drain out and then fluid accumulated and I had to put the drain back in. And I mean, I've had people had to have, 2 drains put back in. I've had it go on for like months. I mean, it can be a really long, drawn out process, which can be really annoying. It's not the end of the world, but it is just like one more thing. But I would say from a wound healing infection standpoint, that doesn't tend to be too bad. The surgery itself actually is easier in my mind most of the time. It's this seroma that really bothers me and the patients, I imagine. Nobody likes having a drain in.
No.
Yeah.
Oh gosh, I will stop there because I know we've already kept you longer than you had time for, but thank you so much for this presentation. It was terrific. And I have a feeling a few of us are going to be watching the videos over and over again to make sure we got it all. A lot of information, a lot of great information, and we really needed this. So much appreciated. Thank you so much for being here.
Of course.
And we hope to have you again.
Thanks for having me.
Thank you.
Okay, thank you. And if everyone else wants to stay on, we have about 15 minutes left. Not quite enough time to do breakout rooms, but